Hey everyone, welcome back to my channel. Today we're diving into the thrilling world of general surgery, focusing on a topic that's as critical as it is fascinating, the acute abdomen. Picture this, you're in the ER, the clock is ticking, and every decision counts. That's what acute abdomen is all about. Life or death situations arising from sudden, severe abdominal pain. So let's break it down. An acute abdomen is a recent onset of abdominal pain, often accompanied by systemic signs like fever, a racing heart, and elevated white blood cells. There are four major culprits here: obstruction, inflammation, perforation, and ischemia. First up, obstruction. Imagine the entire abdomen under siege, like a small bowel obstruction or a large bowel obstruction, but it can also target individual organs like the gallbladder with gallstones or kidneys with kidney stones. This pain is characterized as colicky, meaning it comes and goes, leaving patients writhing in discomfort, unable to find relief. Besides the pain, these obstructions cause other problems. For instance, with a bowel obstruction, patients can't pass stool or gas. This is called obstipation. With gallbladder issues, jaundice might kick in. Moving on to inflammation, think of conditions like gastritis or diverticulitis or any of those itises. This pain is steady and relentless, usually ramping up with fever and leukocytosis. Now, into the nightmare scenario for surgeons, perforation. This can happen due to trauma, peptic ulcers, or even post-surgical complications. Patients describe this as a sudden, intense, and persistent pain. They're often motionless, fearing that any movement will make it worse. Look for peritoneal signs like involuntary guarding and rebound tenderness. These are red flags. Lastly, ischemia. Picture your classic vasculopath, an elderly person with a history of heart attacks or strokes, or someone with chronic atrial fibrillation. The pain here is sudden and severe, and characteristically way out of proportion to what you find on the physical exam. If you see this in the ER, call vascular surgery stat. Time is bowel. So, how do we tackle these cases? First, if there are peritoneal signs, get ready for an exploratory laparotomy. Stat. These signs usually point to most serious conditions like perforation or ischemia. For suspected perforation, a quick X-ray, KUB, can be a lifesaver. Look for gas under the diaphragm, but remember, with laparoscopic surgery, post-surgery, there can be gas left behind and cause the same kind of picture, which doesn't generally mean that there's been a perforation. If there's a confirmed perforation, surgery is the only way out. In cases of obstruction, like cholecystitis, kidney stones, or even a ectopic pregnancy, consider ultrasound or CT scans. Treatment varies. Sometimes surgery, sometimes not. For inflammation like gastritis or diverticulitis, gather a thorough history and imaging with ultrasound or CT. Again, treatment depends on the affected organ and the etiology of the inflammation. Finally, for ischemia, these patients might need an arteriogram or colonoscopy, but if they're unstable, it's straight to surgery to remove the necrotic bowel. Early detection might allow for vascular procedures like a thrombectomy or other endovascular procedures to take place that may save the bowel. So there you have it, the essentials of handling an acute abdomen. These conditions can deteriorate quickly. So always be proactive when a patient comes in with abdominal pain. What's routine for you might be the worst day of their life. Thanks for tuning in. If you found this video helpful, don't forget to like, subscribe, and check out my other videos on all things surgery. Whether you're prepping for your surgery rotation as a medical student or gearing up to take the EBSITE exam this year, we've got you covered. Remember, it's a beautiful day to save lives. See you next time. Thank you.